Today I'll be dealing with phacoemulsification in challenges cases, mainly hard cataract and small pupils. Um, we all know that nucleus management in hard cataract is very difficult. As hard cataract, it will need lot of phaco energy and time to completely emulsify the nucleus. This use of increased phaco energy can lead to lot of corneal problem, corneal wound burn, endothelial problem, postoperative corneal edema. Even it can lead to corneal endothelial decompensation. Generally, in this hard cataract, zonules will be weak and we may produce additional stress over the zonule while attempting chopping, can lead to zonular dialysis, and complication like posterior capsular rupture is also common in hard cataract. Postoperative inflammation is also very common in hard cataracts. In the hard cataract, most difficult part is to completely separate the nucleus into multiple fragments. Usually the posterior leathery plate will be very thick. It is very hard to crack the posterior leathery plate. So my technique is to make a very deep and wide central trench. Make it very deep so that the posterior plate is very thin and it is easy to crack it. I'll show you a video. It's a grade 4 cataract, brown cataract. For such hard cataract, you need a little larger axis so that you will have some space for your maneuver. Before making the trench, you sculpt the surface of the nucleus a bit so that overall thickness of the nucleus is reduced. Then you start to make the central trench. Make it very wide and deep. By doing this two things, the hardest part of the nucleus, you are emulsifying inside the bag. Then the heat energy transmitted to the endothelium will be reduced and you are making the posterior plate very thin so that it will become easy to crack. So you take time for this step, make the central trench very deep and wider. Once it is ready, then you go for the chopping. You can see the trench is very deep and wide. You can see the red glow through the base of the trench. Now it is ready for chopping. For chopping in hard cataract, you need very good hold of the nucleus. Your grip in the nucleus should be very good. For that, you should have a very high vacuum. Usually I use around 475 to 525 vacuum. The vacuum should be very high and the tip should be buried deep into the nucleus. For that, the tip should be exposed little more. These two things, you will get a very good hold of the nucleus. One is very high vacuum and the tip should be buried deep into the nucleus. Once you get a good hold of the nucleus, then start lateral separation. Lateral separation you do in multiple attempts, not in a single attempt. You do lateral separation, then in the next attempt you go little deeper and separate, and then you further go deeper and separate. Like that, with the chopper, you go progressively deeper and separate. When you do like this, the stress over the zonules will be less. Usually, I use a 1 millimeter sharp tip chopper. It's little longer, so you can go very deep within the bag. You divide the nucleus into 6 or 8 small fragments, then your emulsification will be much easier. If the larger piece, the cotton removal will become difficult. Smaller piece, it is easy to emulsify. See, I am separating the nucleus, then keeping the chopper further down and separating, then again separating. I am separating in multiple attempts. Once all the pieces are completely separated, now it is ready for cotton removal. Cotton removal always protect the endothelium using a dispersive viscoelastic. Once all the pieces are completely separated, your cotton removal will become much easier. You just have to stay at the center of the eye in the pupillary plane. Always stay in the pupillary plane and start emulsifying the pieces one by one. Once all the pieces are completely separated, you will have a very good followability, and the pieces are small, you will have very good followability. And it's like any other normal case, easily it will get emulsified. In between, if you want, you can top up with dispersive viscoelastic to protect the corneal endothelium. Just stay in the center and emulsify the pieces one by one. Always be careful while doing the last piece. There is always a chance of surge. So last piece, be careful. If you want, you can reduce the vacuum a little bit lower. After that, usually there won't be much cortex. You can remove the cortex wash and go for the IOL implantation. Sometimes you may not get a crack in the posterior plate in first attempt. Such cases, you can use a 1 millimeter chopper with a blunt tip. With this, you can go very deep and separate the nucleus without fear of posterior capsule damage. So, you can go with the chopper very deep and separate. It's very safe. Even if you touch the posterior capsule, it's not going to cause a PC tear. And I told the hold is very important in managing hard cataract. Here when I am attempting chopping, the nucleus is slipping. That means your hold is not good. Such case, you have to reassess why the hold is not good. If vacuum is low, you increase the vacuum. If your tip is not buried, you can bury the tip deep inside and then attempt chopping. Then coming to small pupil, I'll show you a video of how to place the iris hooks. Iris hooks, you make small stab incision at the limbus or little posterior to the limbus. Just small stab incision are needed. 4 incision at opposite clock hours. If it is made at opposite clock hours, you will get a uniform dilatation of the pupil. Once the 4 incisions are made, you start introducing the hook through the side port. You can introduce the hook through the side port. You can change the direction of the hook by just rotating the stopper. With the stopper, you can manipulate the direction of the hook and engage the pupillary margin and pull. Like that, introduce the 4 hooks. Always the incision is important. It should be at the limbus or little posterior to the limbus. If it is anterior, you will get a tenting of the iris. So always at the limbus or posterior to the limbus incision is. At the opposite clock hours, your dilatation will be uniform. And after the surgery, after IOL implantation, you can remove the hook, remove the stopper, disengage the pupillary margin, and you can remove the hooks. Always in managing challenging cases, you should have, as madam told, you should have a plan B. Always keep vitrectomy ready. Always keep iris claw or standby sulcus fixating lens ready. With proper planning and management, you can give very good results for such cataract. Thank you.
Thank you, Dr. Sarath. That was a very interesting topic. I would like to add on just 2 points in this. One is, while inserting the iris hooks, I think it is always better to do a capsular access after you insert your iris hooks, because sometimes when you insert the iris hook, you might also hook the capsule, and that can result in a capsular tear. Second thing, when you're doing the trenching, you can go deep and till you see a red glow. So that is the point where you have to stop and you have to start breaking your nucleus. So that was an excellent topic, excellent videos. Thank you.